Hi there, and welcome to Backbone. I thought I'd share with you today the presentation I did at a recent conference in Malta of the International Doctors Forum. And I was very proud to have been asked to present there. It was a very nervous and nerve-wracking time because it was mainly attended by quite eminent GPs, specialist colleagues, psychiatrists, rheumatologists. They were all there. And I had to gel an awful lot into a small time, but it also forced me to distill my ideas. I thought it also nicely exemplifies how we think at Backbone, mostly that we actually try and link the multiple sciences that we now have in medicine that I think we have verged on becoming very reductionist. We've become stuck in our ways and stay in our silos and probably not communicating an awful lot of information that we should be sharing that is clearly linked. This is my first slide, and on it is a quote by one of my great heroes in stress medicine, Hans Seeley, who in 1937 first began to realize that people who suffered with stress underwent adaptive mechanisms, particularly in their physiology when they became stressed, and that they would secrete more adrenaline, and that this long-term effect had long-term health, physiological, mental, and immunological. Your immune system responded as well. And the paragraph, I think, nicely exemplifies our philosophy here at Backbone. It is not to see something first, but to establish solid connections between the previously known and the hitherto unknown that constitutes the essence of scientific discovery. It's the process of tying together which can best promote true understanding and real progress. And that's reflected in our attitude to treating patients, is that we have a very joined up approach, and we involve the integrated medicine practitioner model, which is that we don't always need to have everybody under one roof, but that we have a multidisciplinary team approach at meetings when we discuss patients with difficult or complex problems. And it's a philosophy I'm very proud of and has gleaned some amazing results with patients. And the second phrase at the bottom, the reign of pain rests mainly in the brain rather. And this is a nice reflection that we now know from neuroscience that most long-term persistent, or as they used to call it, chronic pain, actually is a manifestation of the brain putting a brake on movement and activity based on the fact that it is fearful of damage, and that sometimes changing patients' perception of what's going on is as much a treatment as anything we do physically or actively to help them, all of which we can draw upon if we need to. So going to our first slide, as an example of how we would like to show our linked up thinking here at Backbone, I presented on the relationships between hypermobility, which is flexibodies, people who have a low collagen in their bodies, and why they have problems. Linking it to dysautonomia, which is a very complicated word, simply meaning the sympathetic nervous system becomes unbalanced. Neurodiversity, we've now found that actually a body type of hypermobility can actually produce a neurotype. And we are probably going to call it something different, but it has an ADHD type nature to it. And also why the pain system that we have in our bodies becomes hypersensitized. In fact, all of the sensory modalities, touch, taste, noise, temperature, etc., becomes hypersensitized, so that people's threshold for being stimulated by those modules is very sensitive. And so they link together and they produce a very specific form of response in the nervous system. So as a little bit of background, just to start off with, when I was writing my book back in 2018, The Meaning of Pain, I was having to do conducting an awful lot of research into a lot of the journals that, of course, many of us aren't reading because there's so many subspecialties: neuroscience, pain medicine, rheumatology, etc. And one of the things I unearthed, which was quite shocking to find, was that currently 43% of the UK population currently suffer with persistent, or what we used to call chronic pain. And that's British Society of Pain data, so it's very reliable from big studies. That means that's 23 million people currently suffering with that kind of pain. And it costs the nation more than cancer, diabetes, and heart disease combined. As a subset of that pain, of those different pain types, 85% of that is either back or neck pain, so spinal pain. And then 20% of those as a subset are hypermobile. They have flexible bodies. So this was very obvious to me that there are a large number of patients who, as their underlying cause to their pain, was in fact this hyperflexibility in their joints and soft tissues. So I looked into this, and that's where we started to formulate this connected science and how we could then go on to find solutions to help the patients. So under a separate heading, which is more rather more friendly to use is bendy bodies, bendy brains. How does a physical problem, hypermobility, lead to neurodiversity and pain system hypersensitivity, or chronic pain as it was previously known? So we began to ask ourselves, how does a physical problem, collagen deficiency, low collagen in the body, manifest as a neurotype, or a specific pattern of how the brain computes and approaches the world? And how does our neurobiology therefore go on to actually make us hurt? So as we now know, hypermobility is in fact quite a spectrum disorder. You can have quite minorly extra flexibility in your bodies and in your tissues and joints, or you can be on the extreme end, some conditions called Ehlers-Danlos syndrome or Marfan syndrome, and there are a subset of other ones who really do have quite a significant amount of problems, but are luckily relatively rare. But as in normal joint hypermobility, we discovered it's actually up to 20% of the population. And interestingly, it's 4 times more common in females than males. So this is very relevant to female medicine. And therefore, we really need to isolate its origins, its causes, and hopefully its solutions. Just to go over some quite reliable symptoms and signs of the condition. Very often they have frequent joint ligament injuries. So very often patients will come and see me and say, oh yes, all the time I kept twisting my ankles at school. And then they had problems with balancing and they kept repetitively twisting their ankles. And that's because the ligaments have become damaged and they feed back to the brain even less well than they were in the first place. Joint and muscle stiffness, they feel constantly that they're stiff despite being very flexible. And this is because they're having to recruit extra muscles in order to stabilize their joints, which obviously inevitably become fatigued, and they feel that as stiffness. They're also very tense internally, so they tend to contract all of their internal or intrinsic muscles, their deep muscle units, which leads to fatigue ultimately and uses much more energy. They very often get pelvic floor pain and dysfunction. So again, in ladies and females, but even if they haven't had babies, they can produce problems relating to incontinence, or they can get pelvic pain when they are sitting off of the time, which can also spread and move out through the pelvis. They often describe tiredness or fatigue and brain fog, which is the inability to concentrate. They seem to be switching off from what they're attending to, and that relates to the kind of ADD neurotype that we'll come back to later. The reason I've highlighted clumsiness and poor balance, as well as dizziness and fainting, or dysautonomia and low blood pressure, is this is what causes the disturbance of the internal physiology of the body, which feeds forward into the brain and causes a sort of anxious state. And then they very often have quite thin, very soft often, and very stretchy skin. They can pull the skin out of the neck or the back of the hands more than normal, even in young patients. They very often bruise a little bit more, and so when they say, yes, when I bump into things, I often get a bruise very easily. And when we describe this as a normal part of hypermobility, it's quite a revolution to them. The venous dumping, as we call it, when patients get up with hypermobility, they very often have low blood pressure. So when gravity acts on the blood system, they dump it into the pelvis and often into their legs. And they often then perceive a moment of sort of slightly pre-dizziness and pre-fainting type symptoms. There is in fact a score which is very easy to conduct called Baton's score, and the picture is up here. It's commonly represented by being able to touch your thumb easily to your wrist, hyperextending elbows past 10 degrees, being able to touch your hands flat on the floor without warming up, particularly in the morning when you'd normally be stiff, hyperextending knees, so the elbows and knees tend to push backwards, and very often being able to extend the little finger to 90 degrees or above. I would also add in stretchy skin, but those are the key elements. It's out of 9, and if you score about 6 or above, then we would consider you to have joint hypermobility. So this is a nice overview of what tends to occur in the bodies. It's easy for patients to assess, and very often it rings a bell with them, and it's their own personal lived experience. This slide's a little bit technical, but it contains some quite interesting data. Because in the medical world, particularly if you're trying to convince colleagues, you really have to have some evidence for these linked criteria and also these linked entities. I have been unbelievably lucky to work in conjunction with Professor Jessica Eccles, who's at Sussex University Hospital, and she's a leading brain in this link between hypermobility and ADHD, attention deficit hypermobility disorder. And that just means very simply that very often people have an inability to concentrate, they're easily distracted and disturbed, and they tend to get quite tired and fatigued quickly, and they also tend to present with being overactive and moving. They also get quite impulsive. They jig their feet. They often have little tics or something, and very often they'll drill their foot when they're trying to concentrate and so on. That's what we call hyperactivity. In boys, they tend to present more with the hyperactivity. The girls tend to have less of this, but actually, and often mask it for longer. That's why it's so important to find these phenomena in younger age female patients, because we can help them much earlier, particularly in their learning and neurodevelopment at school. So just very quickly, you're 7 times more likely to have an autism diagnosis and 5 times more likely to have an ADHD diagnosis. In 2022, a large cohort of neurodiverse patients were analysed, and 50% of them, half of them, met the criteria for joint hypermobility. So these things were clearly correlated. In the neurodiverse female group, 70 to 80% were scoring high on the joint mobility scale, and they also reported significantly higher levels of pain and autonomic symptoms, so the dizziness, the feeling faint when they get up quickly or they change position. And in 2020, Queen's College London studied 3,000 patients, so it was statistically significant, and they showed that hypermobile patients who'd had COVID, they were 30% more likely to have long COVID, which is also an interesting finding, but is related to the physiology and the immunology interacting. MRI studies, interestingly, have shown that many of these patients have some parts of their brain that are slightly smaller, particularly the parietal lobes, which are responsible for body mapping your self-image, but also where you are in space, and the proprioception, which is balance and coordination. And they also tend to have larger and more active amygdala and the insulae. These are both centers for emotional and memory centers. So it's clearly related to heightened levels of anxiety and fear perception, which is all quite interesting. So just to show some evidence for what we're saying, this was a great set of studies, and the work is ongoing currently. So now we need to move to what we call perception, which is how the brain builds up models of the world, moves and acts within it, and also how it forms a pattern of its body image. And we use 2/3 of our brain capacity to process visual imaging. So we're very heavy on our vision, and our central vision is high resolution color, and our peripheral vision is actually black and white, and only tends to pick up moving objects, novelty, things that are in the environment that are dangerous to it. So it's all very primitive, and our brains still work on that basis. We then take our visual information and we try and correlate it with our other 5 senses. So if we're seeing something, we try and hear it, orientate ourselves towards it, and we may then go and feel it, touch it. So it has texture, it has surface orientation, and also we'll feel if it's hot or warm, etc. So we build up models of the world on the basis of the interaction between 6 senses. And I say 6 because the 6th, which has been very much undervalued, is proprioception, which is where are we in space relative to other things. I know that I'm standing on the ground because receptors in my feet are giving me feedback, and I know when I'm moving or changing because those receptors give me orientation. And what we've discovered, and so very much we're actually an embodied brain. The idea that we're all obsessed with cognition and thinking and being intelligent and IQ, but actually the brain is nothing. It is in fact effectively a blank slate without being able to build up models of the brain based entirely on the information you receive from your body. So looking after your body is as important as it is to look after your brain. In fact, if you do one, you do the other. And I'm trying to reverse really how we see those entities, because we all do our Sudoku in the morning and we do our crosswords thinking it's going to enhance our neural function. But more importantly is actually movement and exercise and balance and coordination and integrating that with our visual system. In the hypermobile patients, they have a mismatch between the visual system and how they orientate in space. And the brain picks that up as often sometimes dizziness, but also it represents as clumsiness. That's not dyspraxia. They can hit a tennis ball absolutely fine, but they do tend to knock into things. So they might reach for the salt and knock over the glass of wine. So very often they're teenagers or kids who are often the putzes at the lunchtime, and the parents can get quite irritated by it. They tend to just knock into things or just slightly overbalance. So it's quite a subtle problem, but it manifests in a very real way and produces poor perception of the brain of the world. And I'm going to go on to explain exactly how that occurs. I thought I'd share with you this particular slide. It all looks very technical, but actually the concept is quite simple. About a few years ago, I think it was 2011, two very clever ladies who got the Nobel Prize for their discovery discovered these little suckers here, which are basically what we call piezoreceptors. They're actually propeller shaped, and at the very nano level, they're very small, and they're buried into the soft tissues and into the soft tissues of organs and blood vessels. And they're grouped into two types, piezo 1 and piezo 2. Piezo 2 are the ones initially that we want to deal with because they are buried into the deep capsules of the joints, the ligaments, the muscles, and the soft tissues. They're also buried into blood vessels. Piezo 1 is buried in moving organs, so lungs, things that the kidney because it regulates concentration, skin, the colon because it's constantly moving, so it can regulate the relationship between feces moving down the bowel, and obviously bladder, because as the bladder stretches, it gives feedback to the brain about how full it is. So the piezo 2s give you feedback about where you are in space and how you orientate within it. And the piezo 1s give you internal information to your subconscious brain about the state of your organs and feedback constantly to the hypothalamus, which is the regulatory structure in the brain. It is monitoring your body internally at very high resolution. Those come up to the center of the brain where they're processed and they're orientated together. So the discovery of these little receptors was not only incredibly important, but it explained how the body was picking up movement and then transducing it into information that went to the brain. So these little receptors were a major leap forward and of course help us link why the hypermobile to the normal body has problems with perception. So now I move on to how these piezoreceptors are important. And obviously we said before that these little tiny receptors are buried in the soft tissues. Now, in the hypermobile patients, it's as if they're buried in marshmallow instead of chewing gum. So the idea is you have to have a bigger deflection of movement in marshmallow to register the movement in these little receptors. So as you're trying to balance yourself, you have to have a bigger fall left or right to register that you're actually moving relative to what your eyesight's telling you. Whereas in the chewing gum concept, they're much tighter and more reactive. So there's a more agile response to movement. Why does this cause a problem? Because when you are taking your visual information and there is a delay, a mismatch between your physical body and what you're perceiving, then you end up with clumsiness. Now, unfortunately, when we were roaming the plains, clumsiness was dangerous to us because it meant that if you couldn't run away from the saber-toothed tiger without tripping up over the tree stump in front of you, you were dinner, you were toast. So it created an internal sense of fear, which of course manifests often as anxiety. But most importantly, the mismatch is registered in terms of the response between the visual targeting and the body positioning. We call this in cyberkinetic theory prediction error, because the prediction you have of the world was wrong when you bumped into it. So you need to constantly self-correct. What that unfortunately means is the brain has to take more samples of the world to build up the difference between those, to decrease what we call surprisal. The brain doesn't like surprise because it's very dangerous to it. It means the world isn't quite as you thought it was, and I can't orientate myself within it. So then the brain goes into what we call a hypervigilant state. It's constantly on, which is effectively a stress state. It has to be alert to the world all of the time. So it increases the sampling rate high, but the problem with that is that, of course, it's neurally, the energy that is donated to the brain at any 1 second is exhausted much quicker. So it's like having a Ferrari brain instead of a Ford Escort brain. And of course, you use that energy much more quickly. And so very often they go up into a fight-flight response, but if they get neurally exhausted, they actually go into what we call a freeze response. And I'm coming to that next. So quite apart from the physical information that's coming into the brain about the external world, which you're trying to monitor all of the time and upgrade and orientate, the part of the brain deep down in the most primitive center called the hypothalamus, which here you can see, these are the various nuclei as we call them, and what they do is they monitor things like temperature, concentration in the kidneys, and the general physiology of the brain. That is actually monitoring that internal state at a very high resolution. Your brain knows what's going on inside your body very, very intently. You just can't be made conscious of it because it would be too much information. But when, for example, if you feel thirsty, you know what that feels like. And it's what we call affect. It's a feeling. You can't really describe it. It's just a need to drink. That comes forward to the front of the brain as a need. Your brain interprets that, and it satisfies it with a motor outcome, which is I need to drink. Same with food. I'm hungry, comes forward as a feeling because I need energy or I need nutrients. And so the brain perceives that as hunger, which is a drive to move forward and pick up food, etc. All of which in the old days and counter times would actually put us at risk of predators. So using energy is actually very adverse to our brains. Now, to change that internal state and to make adaptations and compensations, there is a fundamental relationship between three things: blood pressure, breathing rate, and pulse rate. And they actually work together in a very clever mathematical model. And we call it respiratory sinus arrhythmia. It's a ridiculously long term, but it's very important because if there is asynchrony between it, then you can't maintain your blood pressure and ensure the highest amount of oxygen around the body for the fewest number of pulse beats. So this becomes a problem and very often results in a phenomenon we call POTS, which is postural orthostatic tachycardia syndrome. Again, another ridiculously long term. It just means dizzy, unwell. Sometimes you feel hot, panicky, etc. But particularly when you get up or you come back from lying down, particularly in hot weather. So hypermobile people very often don't like the hot weather because they open up their blood vessels to lose heat, which changes the internal regulation. Again, it makes them feel more unsteady and more dizzy, and that's frightening. So if they don't understand it, it makes them anxious. One of the ways that you can adapt to that is you can change your breathing pattern. And as you will know, for us guys here at Backbone, breathing is unbelievably important. It's in fact my greatest passion, and I've been teaching it for 25 years. And if you monitor breathing, you can pick up that these patients tend to be breath holders. They tend to hold their breath a lot. They breathe the wrong way round, which is an inverted breathing pattern, and they tend to hyperventilate. So they breathe too quickly and too shallowly. So again, they're in a slight stress state. Hypercapnia, that word just means they have very low carbon dioxide. Most of the breathing dysfunction we see in these patients is not a problem of oxygen. It's that they're puffing off too much carbon dioxide. For example, when you see somebody having a panic attack, the ambulance driver might give them a bag to breathe into because then they're recapturing the carbon dioxide and then they can return to normal and then they don't feel panicky. So you can see why with these physiological internal changes, these patients are beginning to feel very anxious and they don't really know why. And actually biology never gave us an affect, a feeling to compensate for this. So it defaults immediately to a fear response. Also, we get musculoskeletal, that's what the MSK stands for. We tend to get symptoms in our physical body because the changes in our physiology means that we can't get rid of lactate, which is the side product of metabolism, particularly when you're taking exercise, and it tends to load up in the muscles. And that actually causes irritation to the small nerves in the body and causes irritation and pain. So this is where we begin to see the pain developing. Also, because we're priming to run most of the time as a stress response, the deep motor units in the muscles are actually firing all of the time. This is often why patients, although they're hypermobile, feel stiff because they're slightly fighting themselves when they move because they're preparing all the time to flee. So they produce tension. They often produce things called trigger points, which are sensitive sore points on the body, which is often diagnosed as fibromyalgia. Again, it's a diagnosis generally, I think, is a poor one. It just describes a set of symptoms that we don't properly understand. But this is where these trigger points develop from. Eventually, the feeding forward of the internal state comes to your prefrontal lobe as affect turns into fear and anxiety. So we can see now immediately how the nervous system is beginning to have to constantly be on alert, constantly be afraid effectively, and constantly find out more information by making us hypervigilant and very self-aware. In stress medicine, and this is one of Hans Seeley going back to his first quote earlier, one of the concepts that he came up with is completely true, is we often talk about fright or flight, a stress response. And we're very good at doing that and we can respond to it, but we need to come back off it to recover. If you are in a state of constant fright or flight, there is a third phase, and it's very, very often not spoken about properly, which is freeze. Fright, flight, freeze. In a freeze state is really a state of exhaustion. And the brain will sabotage you. So it's not you and your mind, etc. You're not making it up. Your brain will send signals to say you can't keep this up, which is brain fog. So the three horsemen, as I call it, of the freeze phase are brain fog, which stops you thinking, makes you opt out and stop and conserve energy. Fatigued, which does the same thing. It makes you feel tired, and so you cease to move, you take rest, etc. And then pain, because pain is a physical response to the perception that you're going to damage yourself And so it gives you a concept of pain. So it's really a feeling. Pain is an affect, a feeling, which is unpleasant and stops you moving. So again, it's a sabotaging event. Lastly, you get inflammation because, and this is at the heart actually of the placebo concept, which is that the perception of the brain is that it's at danger, which is that it could be being chased, etc. And it will initiate an inflammatory response, which is full of immune responses, in order that if we were bitten or if we had injury from fighting, we will be able to very quickly switch on the genes that were there for healing. So inflammation isn't necessarily our enemy, it's actually our friend, but it's there too much. You can have too much of a good thing, and this leads to other problems, which is itchy skin, oversensitization to small stimuli, so they get itches, rashes. They're more sensitive to generally to irritating stimuli like bee stings and so on, hives, heat rash, and so on. So these poor patients are really in quite a state. They're disrupted internally and they can't get a handle on the world externally. And that's a dissonance inside the nervous system, which is perceived as stress. And if that goes on long enough, they can go into a kind of collapse phase, producing all these symptoms. So you can see how we've linked all this science together. And it's also been, really, in my view, proven by several years of using this model with patients and getting some really fantastic success. So I've just put this middle slide in because it's a summary of what I've just said in the more visual slide for those who find visual learning easier. And this is a nice little summary of the science that we've linked together. So I'm not going to read through it now, but I thought as a little joke when I was at the IDF giving the speech, they like a technical term, all these scientists. So I put together an overview scientifically of what these patients are suffering with. And we call it limbogenic neurological hypersensitivity with resultant pathogenic arousal. So there's a nice mouthful for those technocrats out there. But basically, this is a nice summary slide for you to read. So as backbone of the solution people, what do we do about it? Well, we formulated a pretty rigorous approach, and you can see from some of these pictures, these patients are often given breathing monitors so that we can teach them to recognize when they're breath holding, sighing, yawning, all the indications that they've gone back into hyperventilation. Because a lot of people who hold their breath during the day don't know that they're doing it, but that in its own right is as much a problem as the speed and pace and depth of the breathing. In my clinic there, you can see the picture down at the bottom. I assess patients with a monitoring system, and we look at their blood pressure, their pulse rate, etc., and then teach them to breathe, give them control back because they can get feedback about their breathing, lowering their blood pressure particularly. It's very effective for lowering blood pressure. In fact, some of my patients have come off medication as a result. And getting the feedback in their pulse rate lowering and their blood pressure. That's very powerful, if only also because it understands that they now have control over their symptoms. There's something they can do rather than endlessly needing medication or needing doctors to attend to them all the time. So, and that of course alleviates fear, which down-regulates the sympathetic, we call it, or stress response, and they almost automatically feel better. Also, I didn't mention that actually some of these patients will often have IBS, irritable bowel type symptoms. Again, I don't think this is really a true diagnosis. I think it's a bowel that is shut down due to a stress response because, again, roaming the plains, if we were going to be chased, we would shut down our bowel in order to distribute the blood to our periphery and to our limbs so that we were more efficient, and also to our brain so that we could think how to run away and avoid our predators. So I think most of the time these patients are just trying to digest with a bowel that's shut down to doing so. And of course there are gut biome effects, but I think they're rather less than actually the nervous system just not being in a neural state where it can actually digest. So just quickly going through the list of things we do a rigorous, very rigorous, intensive case history that in fact includes even going back to childhood, because sometimes people are also stressed from things that happened in their childhood and how we can link that to feeding forward to their adulthood, but also things in their lifestyle that could be stressing them. So we can help them treat their symptoms also with just things they can change in their lifestyle. Hacks, as we like to say, things that you can do, sleep and so on. We give them a full neurological exam, musculoskeletal exam. If necessary, we can send them for a thing called a tilt test, which is to see if when they're tilted up to 45 degrees and they're on monitors, whether they drop their blood pressure in an unusual way. And then we can help them with that too. Sometimes it's medication, but very often it's just compression, special types of exercise and so on. Many of the patients will suffer with what we call upper cervical instability. And to be very clear about this, this is not what we call surgical instability, but it's the way that due to their breathing pattern, they switch how they stabilize their necks. And this feeds forward as neck pain, headaches, and very often sometimes a mild form of vertigo, which again we can also correct. Sometimes if their abdominal walls are dysfunctional, if they don't have great core or they've had babies, etc., and they're not able to stabilize through the bowel, then that increases the chances of them dumping their blood flow into their pelvis. So again, we can teach them specialist exercises that are not sit-ups, not planks, special interactive integration exercises of a muscle wall, which can respond very quickly, and they find huge stability in their dizziness. We try and resynchronize the relationship between the breathing rate, the pulse rate, and blood pressure, which is important. When that returns to normal, they feel enormously better and much clearer headed. We look at trigger points in the body, sore points in the muscles that we can release off, teach people to self-release and give them a program. Desensitization, so we can make their nervous system much less sensitive to normal stimuli that are making them over-respond. And we use manual release techniques, so they could be massage release, so they could be specialist exercise, all sorts of things that we can integrate. Also, we've put together here at Backbone very highly specialized exercise regimes, which other things like sometimes Pilates actually can aggravate hypermobility. And we do closed chain exercise, but very orientated around stabilizing the center first and then moving to the periphery. So they have a very set program, which they gradually introduce, won't make them sore, and will very quickly restabilize their ability to perceive the world better. We sometimes use compression so that we can return the venous system back to the heart much easier. And then once patients have got their exercise back up, the muscles and tendons tend to do this instead. One of the biggest and best treatments we give patients is education. We constantly share with them and reinforce with them the science and made into an easy and simple form that links all of this. And very often my patients actually leave my room crying, but of joy, saying somebody at last has told me why I'm like I am and why my life has been as it is, but also more importantly, that I can stop seeing an endless sea of practitioners and take control myself. And that's very, very important. And we're always there to help them and support them in the future, but very often we'll find they can manage these things on their own once they understand it and they're less fearful of the problem. So bringing all that science together, explaining it to them in an easy and digestible way is really, really important. And I would say it forms probably 60% of the treatment in real terms. It also engages them because once they see a change, they're much more active in helping themselves. So lastly, at Backbone, we use what we call an integrated practitioner model. So we have our core practitioners who are there most of the time if necessary. Otherwise, we can refer to a really enviable network of fabulous practitioners and medical specialists of all types, which I've developed really over 30 years of practice. And what's so lovely is that they are as excited by this as I am, because they have so often been sitting in their specialty silos, knowing a lot of this stuff, but not being able to either link it or find other people of like-minded, joined-up thinking that want to be involved. So we have a fantastic network of rheumatologists, psychiatrists, neurologists, cardiophysiologists, which is for all the blood pressure stuff, and also some fantastic specially trained remedial exercise experts, as well as gastroenterologists that have a special interest in hypermobility. And they are as excited as I am, as I say, that we're beginning to link this science and we can provide a conjoined, joined-up approach to patients. We do this by a weekly multidisciplinary team. Some of it's coming from digital interaction on Zoom and the likes, and some are actually present in the room. But what we will use them to do is to look at imaging, look at tests together, draw on the specialist knowledge of all these practitioners so that we can best formulate a treatment plan and approach and a constantly developing process with the patients, particularly if they've come with very complex symptom pictures that are not necessarily obviously linked, but quite clearly are. So we're very proud of that network, and we will choose for the patient the person that is best able to treat them. Sometimes even the personalities we match up, and that's very important because you've got to trust your practitioner. You've got to get on with them because it's a therapeutic relationship. So I hope you can understand that's an overview of what we do at Backbone. And if it looks like what you're looking for, come and see us.